Frozen shoulder. What is it and how to treat it? Frozen shoulder, or adhesive capsulitis, has been described as an enigma, a condition of uncertain etiology characterized by substantial restriction of active and passive shoulder movement and occur in the absence of a known intrinsic shoulder disorder. It can be incredibly painful and incredibly debilitating. So what is actually affected? This is a diagram of a shoulder. We're going to take an axial section and rotate out the humeral head. So we're now looking down at the shoulder, end on, having removed the humeral head. The structure that's actually affected is the capsule. This is the innermost layer of the shoulder responsible for producing synovial fluid. The ligaments, tendons and muscles outside of this are generally completely unaffected. For some unknown reason, the capsule suddenly becomes incredibly inflamed and painful. As time goes on, this inflammation becomes greater and greater. This is an arthroscopic view of a shoulder in the inflamed stage of a frozen shoulder. You can see the capsule incredibly red and inflamed. Over time, the inflammation tends to settle, and as this does, the capsule then begins to scar up. As time goes by, this scarring gets greater, and the capsule thickens and contracts down, restricting all movements in the shoulder. As time continues further, this scar tissue then begins to slowly resorb, and eventually the shoulder is said to fully recover. A classic frozen shoulder is said to have three symptom-related phases. The first, or the freezing phase, is when the capsule becomes increasingly red and painful. Over time, the shoulder becomes so painful, constantly there, day and night. At the same time, the shoulder is slowly stiffening up. As the inflammation tends to settle and the capsule scars up, the shoulder then enters the frozen phase. This is when the shoulder's movements are completely restricted. Over time, the capsular contracture then slowly resorbs, and the shoulder movements begin to thaw and return to a near full range. The varying severities of a frozen shoulder. In some cases, this only lasts a few months, and by the time the patient feels that his shoulder is bad enough to see the doctor, it's beginning to recover. A classic frozen shoulder lasts for about 18 months, each phase lasting about 6 months. In the most severe versions, this can last for far longer, and the recovery of the range may not fully occur. So what is the etiology of a frozen shoulder? Why do people get it? We know a conservative estimate is it has a 2% incidence in the general population. It tends to affect people between the ages of 40 and 65 years of age. It tends to affect women slightly more than men. However, anyone at any age can get a frozen shoulder. There is no obvious or known cause as to why people develop a frozen shoulder. It often occurs in people who are otherwise completely fit and well. However, it can be related or precipitated to a shoulder injury or other underlying shoulder pathology. We do know that people who do have diabetes do have an increased incidence of developing a frozen shoulder and tend to have the most severe version. Although everyone with a frozen shoulder does have 3 symptom-related phases, their history can be very different, and no two people are the same. There can be a variable onset. Some people notice a gradual onset of pain, others notice a sudden pain when they wake up one day, and others can develop it following an injury. In the early stages, it's sometimes difficult to differentiate a frozen shoulder from other shoulder conditions such as a tendinitis. Over time, the pain gradually increases and can become constant day and night. The pain is around the shoulder and often radiates down into the upper arm, even down into the fingers. Some people describe it as a blood pressure cuff-like tightness around the upper arm. Initially, people have a good range of motion, but as time goes by, the movement slowly deteriorates. Over time, the pain slowly deteriorates, movements of the shoulder become less. People find that they're unable to reach behind them, they find it difficult to turn their arm out, and they often have to hitch their shoulder up to compensate for movements. As time goes on, the shoulder enters the thawing stage and the movements gradually return. However, the muscles, which haven't actually been affected by the condition, are often weak and fatigue quickly. Patients may not regain a full range of motion. As mentioned earlier, there are varying severities of a frozen shoulder and various timelines. How do you diagnose a frozen shoulder? Well, this is really down to history and examination. Obviously, it depends on the stage at presentation. Some patients present early in the freezing stage, Some more stercal patients present in the frozen stage, and some as late as the thawing stage. Investigations for a frozen shoulder tend to be normal. Blood tests are normal and show no evidence of any systemic inflammation. An X-ray is generally normal and is undertaken to rule out any underlying pathology such as arthritis. An ultrasound scan again is normal and is used to rule out any underlying pathology such as a rotator cuff tear. However, an MRI scan can sometimes show pathology. It can show a thickened joint capsule with decreased volume within the capsule and pericapsular edema surrounding it. Treatment of a frozen shoulder, particularly in the freezing stage, has traditionally been supportive in the form of non-steroidal anti-inflammatory tablets, painkillers, cortisone injection and rest. Physiotherapy is in fact contraindicated. Trying to force the shoulder to maintain movement in fact probably stirs up the pain further. However, a relatively new treatment called hydrodistension has made a massive impact in treating patients in the freezing stage of a frozen shoulder. Hydrodistension is undertaken as an outpatient procedure and takes about 30 minutes. A consultant radiologist puts local anaesthetic around the shoulder, then under image control a needle is inserted into the shoulder joint itself. Radiolucent dye, normal saline and cortisone are then injected into the shoulder. Initially, only a small volume of fluid can be injected into the contracted capsule. However, under pressure, the fluid is then able to distend and potentially rupture the capsule. It is thought that this process breaks down the adhesions and encourages the capsular inflammation scar tissue to resorb. Following the procedure, the patient needs to undergo aggressive physiotherapy. Hydrodistension is particularly good at getting rid of pain and also increasing range of motion. Some patients notice an almost immediate response within a couple of hours, but over 80% of patients noticed a marked improvement within 2 weeks. The 10 to 20% of patients who only gain a minimal response or relapse can undergo a repeat procedure, and over 90% of these will then gain a successful result. For the small group of patients who fail to benefit from hydrodistension, have a severe or protracted contracture, or have diabetes, an arthroscopic capsular release is indicated.
Arthroscopic capsular release for frozen shoulder. This is a left frozen shoulder in a 49-year-old lady that has failed to respond to 2 previous hydrodistensions. You can see a tight capsular contraction involving the capsule and incorporating the long head of biceps. Initially, a spinal needle is used to locate the inside-out position for a cannula. You can see the very thickened capsule within the rotator interval. A long-nosed capsular release punch is then inserted. The punch then finds the plane between the capsule and the subscapularis tendon behind it. Then working inferior, a strip of capsule is removed close to the articular edge. As the release progresses inferiorly, the joint opens up, allowing better visualization with the scope as it heads towards the 6 o'clock position. The release finishes just short of the 6 o'clock position to protect the axillary nerve beneath it. Having released the anterior-inferior capsule, attention is now taken towards the rotator interval. The radiofrequency probe is used to remove the tight capsular material from within the rotator interval. We can see subscapularis being revealed. Working superiorly, the rotator interval tissue is released right up to the anterior edge of supraspinatus and the long head of biceps. The radiofrequency probe is now releasing the tissue between the superior part of the long head of biceps and the capsule above it. This allows access to the punch to be brought in to release the tissue between the superior part of the labrum and the capsule above it. The scope is now in the anterior portal and we can see the release of the superior capsule and the tight posterior capsule. The capsular release punch is brought in again posteriorly and works its way down inferiorly, releasing the very tight contracture. As the release progresses, we can see that the joint opens up and it becomes increasingly easy to see the joint. As the release heads towards the 6 o'clock position, we get a nice view of the joint. Once again, the axillary nerve is protected. Strictly, a frozen shoulder only affects the capsule. However, most patients do have associated rotator cuff disease. As a standard, I incorporate a subacromial decompression at the end of the procedure. Whilst in the subacromial space, I could then insert a pain pump which helps with post-operative pain management and mobilization. The pain pump catheter is inserted and will provide additional pain relief for mobilization.
Following a capsular release, it is essential that the patient works on regaining range of motion. Strong analgesics are given and a pain pump is often inserted into the shoulder at the time of the procedure. Physiotherapy is required on a regular basis and exercises must be undertaken 3 or 4 times a day, initially for the first 2 to 3 weeks. It can take some time to regain the flexibility, strength and stamina of surrounding muscles. If you'd like to know more about the treatment and management of frozen shoulder or any other shoulder conditions, you may wish to visit my website www.cambridgeshoulder.co.uk. It covers all of the general shoulder conditions, sternoclavicular joint conditions, and gives patient information. There's a research and education section which has a number of other videos and narrated talks which may also be of interest.